Good afternoon, everybody. I warmly welcome all of you for the next session. This is about brief visits. And I am Dr. Shamita Dasanayaka, and my co-chair is Dr. Roshan Lianage. And we are having two speakers today. Let me introduce the first speaker. She is Dr. Primali Jayasekara. Primali Jayasekara, she is Head and Department of Mycology, Medical Research Institute, Colombo. And I think these days she doesn't need any introduction for this audience. And Primali, may I cordially invite you to speak about rhinocerebral mucormycosis. It's over to you.
Thank you, Shamita. Good afternoon, everybody. First, I would like to thank Sri Lanka College of Internal Medicine for giving me this opportunity. Today, my topic is rhinocerebral mucormycosis. I will be speaking on introduction, epidemiology, clinical manifestations, signs and symptoms, radiological and laboratory diagnosis, antifungal and surgical management with prevention. Introduction. Though colloquially known as black fungus due to its predilection for vascular invasion causing thrombosis, infarction and necrosis. But in mycology, black fungi is a different group of fungi which produce melanin in their cell walls. This infection is difficult to diagnose, rapidly progressive, rare infection with high morbidity and mortality. It has an aggressive angioinvasive infection, and it has a worldwide distribution, and incidence is rising globally as well as in Sri Lanka. And this is mainly due to uncontrolled diabetes. And this is the second most frequent mold infection in immunocompromised individuals. Epidemiology and the etiology. Mucormycosis, those organisms which cause mucormycosis belonging to few genera, order Mucorales and phylum Mucormycota. And this Mucormycota comprises of 55 genera with 261 species, and among them 92 are human pathogens. Among the causative agents, Rhizopus, Rhizomucor, Mucor, Lichethemia, Apophysomyces, Cunninghamella and Succina are the commonest. But among all these, Rhizopus is the commonest worldwide as well as in Sri Lanka. And distribution of different species varies among different geographical regions. These organisms are thermotolerant and they have a ubiquitous distribution. Found on organic substrates, and they are present in indoor environments as well. Causative agents globally as well as in neighboring India, the commonest causative agent is Rhizopus species. This is true for Sri Lanka as well. Risk factors globally as well as in India, the commonest risk factor, the most common risk factor is diabetes mellitus, followed by hematological malignancies, neutropenia, corticosteroid therapy, solid organ malignancy, solid organ transplantation, bone marrow transplantation, hemodialysis, and chronic kidney disease. And please see that there is a small proportion of patients with no risk factors and they are immunocompetent. Mode of transmission, the spores of these organisms inhale through nose and the spores lodge in the nasal turbinates, or they can go directly to the lung alveoli. And in these places, these spores germinate, and this step can be inhibited by macrophages and neutrophils, which can phagocyte conidia. And this step can be inhibited by glucocorticoids and neutropenia. And if this does not happen, these spores can germinate and form the mycelial phase or form the hyphae of the fungi. And this step can be inhibited by impaired glucocorticoids, neutropenia, hyperglycemia, and iron overload. So if this is not inhibited, these fungi can cause the angioinvasive growth in tissues with hemorrhage, thrombosis, and necrosis, followed by dissemination of the infection. Clinical forms of mucormycosis. The commonest is rhinocerebral mucormycosis, followed by pulmonary, cutaneous, gastrointestinal, and disseminated infections. Clinical features, especially rhinocerebral mucormycosis, begins from paranasal sinuses and can spread to involve the orbit, face, palate, and plus or minus the brain. Presenting symptoms commonly fever, unilateral facial swelling, unilateral headache, nasal or sinus congestion or pain, and a blood-tinged nasal discharge. Commonest clinical form, which is the rhinocerebral form, is about 39%, and among the patients, 66% of them are having diabetes. And if left untreated, they could be fatal within 1 week of the onset of infection. You can see from the first two pictures, unilateral facial swelling with the involvement of the orbit. And characteristic diagnostic sign is necrotic black ulceration on the hard palate or nasal terminates. You can see the third and fourth pictures. The fourth one is the lesion in the hard palate but before necrosis. As complications, it can spread to orbit, periorbital or perinasal swelling, progress to destruction of facial tissues. And complications can occur in eye as well, such as ptosis, proptosis, ophthalmoplegia, and loss of vision. If they develop loss of vision, it is very difficult to get back the vision again, however much you treat the patient. And drainage of black pus from the eye is a useful diagnostic sign. From the orbit, it can spread to brain, especially the frontal lobe, and cause necrosis and abscess formation. Radiology, which is very important. CT, from the CT, you can see the involvement of the several sinuses, especially ethmoid and sphenoid, clear unilateral predilection, no air fluid levels, thickening of sinus linings, and destruction of surrounding bone can be seen. MRI, which is better than CT, detects extension of the infection to adjacent soft tissues of the orbit and the brain. These radiological findings are very important for the surgical management, as well as to assess the distribution of the infection, as well as the antifungal response of the patient, because we have to give antifungals for some patients actually more than 3 months. So it is very important to know the radiological, get the radiological evidence. Mortality, overall mortality rate is around 54%, but the varying rates depending on the underlying condition and the site of infection. If the patient does not have any predisposing cause or risk factors, it is about 35%, but with diabetes and malignancies, it goes up. Rhinocerebral mucormycosis, which has the lowest mortality compared to other pulmonary, gastrointestinal, and disseminated infection. That is mainly because rhinocerebral infection can be diagnosed very early with the necrotic nasal turbinates and so on. But pulmonary, gastrointestinal, and disseminated infections, it is very difficult to diagnose, and most of the time we diagnose the patient very late. And highest survival rates can be seen in patients with healthy immune status and without any risk factors. Poorest prognosis in patients with hematological malignancies, stem cell transplant recipients, and patients with extensive burns. And disseminated disease, especially the disease has evolved CNS, it is more than 80% mortality. Laboratory diagnosis, early diagnosis which is essential for successful treatment. Specimens clinical material from necrotic lesions, that is for rhinocerebral mucormycosis, and also following bronchoscopy. Sputum, bile samples, these should be sent in screw cap containers with sterile normal saline and transport at room temperatures. These, why sterile screw cap containers? Because these are very common environmental contaminants in our tropical country. So we will be doing two tests from these samples, direct microscopy and culture. Direct microscopy, which is significant than isolation in culture, because culture, if the direct microscopy is negative and the culture is positive, it could be a contaminant as well. And also direct microscopy results will be we will be doing the direct microscopy on the same day, and the results will be we will be telling you the results on the same day over the phone. Culture isolation is required for species identification and antifungal sensitivity testing. Blood cultures are always negative in spite of their predilection for angioinvasive and hematogenous dissemination. A positive culture from a sterile site confirms the diagnosis, while a positive culture from a non-sterile site must be combined with clinical and radiological evidence, because this is a very common environmental contaminant. You can see the antifungal sensitivity results. Deoxycholate amphotericin, liposomal, and posaconazole all are sensitive to commonly mucormycosis causing agents, but posaconazole is not available in Sri Lanka and not licensed in Sri Lanka, and it is a very costly drug. Serological, no routine serological or molecular tests available, only direct microscopy and culture, but molecular methods can be used to identify the culture isolates. Management tips: early diagnosis based on the clinical signs and symptoms is very important, and you need to start antifungal therapy as soon as you suspect the diagnosis, that is with amphotericin B, preferably with liposomal amphotericin B. But with the current financial situation of the country, whenever possible, you treat the patient with deoxycholate or the conventional amphotericin B. Controlling or eliminating underlying predisposing factors, removal of infected debris from repeated debulking, surgical debulking. This is very important, and each time you do the debulking, please send the samples to the laboratory. And invasive mucormycosis is a medical emergency, and management of it is a team effort. Antifungal therapy, amphotericin B, the liposomal amphotericin B is the drug of choice. But you can use posaconazole and isaconazole. Again, they are not available in Sri Lanka. Itraconazole and fluconazole are not recommended. And the normal dose is 3 to 5 milligram per kg per day, the liposomal amphotericin dose. Conventional or deoxycholate amphotericin dose is 1 milligram per kg per day, but don't exceed 50 milligrams per day, even the patient's weight is more than 50. And doses should not be slowly increased over several days if you are using liposomal amphotericin B, but if you are using deoxycholate, you have to start with 0.25 milligram per kg per day and slowly escalate it to 0.5, 0.75, then 1, and you can continue with 1. Doses more than 3 milligram per kg per day does not result in higher blood concentrations, but this is the dose for COVID-associated mucormycosis patients. They don't recommend treatment with deoxycholate, amphotericin B for COVID-associated mucormycosis, but liposomal amphotericin 7 to 10 milligram per kg per day. How to administer liposomal amphotericin B? You have to do baseline investigations like blood urea, serum creatinine, serum potassium, serum calcium, magnesium, full blood count, and liver function test. Then you give the dose 1 milligram in 50 ml of 5% dextrose over 1 hour while monitoring the vital signs. Prehydrate with 1 pint of normal saline. Then flush the cannula. Then you give the infusion, especially 4 to 6 hours. In liposomal amphotericin B, the manufacturer's recommendation is over 2 to 3 hours infusion. But I would always recommend to give it for 4 to 6 hours, because if the patient develops side effects or reactions to this, we don't have any other drug to give. So because of that, it is always better to give a slow infusion. And then again flush the cannula to avoid crystallization of amphotericin B inside the cannula. Post-hydrate, this pre-hydration and post-hydration is for the to reduce acute kidney injury. And you have to monitor daily blood urea, serum creatinine until the level stabilize. Every third day, serum potassium. If hypokalemia is detected, you have to replace it. And weekly serum calcium, magnesium, LFT and full blood count. Treatment duration unknown. Immune defect should be resolved, and substantial radiographical improvement should be there, and total microbiological cure should be there with direct microscopy and culture both negative. Prevention, adequate control of diabetes, and patients with family history of diabetes, when they are on steroids or after steroids, their blood sugar level should be monitored. Immunocompromised individuals should reduce sources of environmental exposure, avoid contacting with COVID-19, avoid using surgical and K95 masks for more than 4 hours. Thank you.
Thank you, Dr. Primali, for your informative presentation. The next briefing will be on acute visual loss. It's my privilege to introduce the next speaker, who doesn't need any special introduction. You may have not seen him, but I'm sure you have heard his name. He's Dr. Charit Fonseca. He has worked more than 27 years at the National Eye Hospital as a consultant ophthalmologist and vitreoretinal surgeon. At the moment, he is working in the private sector in Navaloko Hospital and Durden Hospital as consultant ophthalmologist and consultant vitreoretinal surgeon. Over to you, sir.
Thank you very much. So I'll be talking for a short time on acute visual loss. It's certainly not uncommon in clinical practice. What we need to know is that it could be partial or total. It could be binocular or monocular, and it could be transient or a permanent loss. The symptoms, at very least, will cause great fright to the patients or any of us who experience it. I have experienced it once when I got my initial migraine attack, and it was quite frightening. Even though I was a medical student at that time, it took me a little while to realize that this was a migraine attack and I was not losing my vision permanently. So it can cause a lot of consternation for patients, and of course it can portend disaster, because if it is permanent, it can involve loss of livelihood. For example, it is very common now for, say for example, heavy vehicle drivers, and there are a lot in Sri Lanka. If they lose visual acuity in one eye below a certain level, then they lose their license, which is the end of their career as a heavy vehicle driver. And it can, of course, be catastrophic in the case if it is bilateral or if it happens to the only eye of a person. So the commonest cause of binocular is neuroophthalmic. Certainly, there are rare occasions when other diseases can cause binocular loss, but the most commonest is neuroophthalmic. And the monocular causes also can be neuroophthalmic, but it can also be retinal, it could be a media opacity, and it could be acute angle closure. One of the things which we occasionally encounter is when patients come and say they have lost visual acuity or they have lost partial or total vision in the last week or a couple of days preceding it, and only to realize that this has been there for a long time. And it is a sudden realization of a non-acute loss. And it could have been there for years, because usually people don't close one eye and check the vision in the other eye, and they do so only if something happens to the eye. So that is also a cause of where patients can present as acute loss of vision. Now, neuro-ophthalmic causes, I'm not going to dwell a lot on it because I think all of you are very, very familiar with neuro-ophthalmological causes as in acute loss of vision. And generally, when we approach, we divide it into cerebral cortex and visual pathway problems, optic nerve problems, and of course, for us, a very important cause is end-stage glaucoma, which is very common in Sri Lanka, untreated end-stage glaucoma. So if you look at the cerebral cortex, we could have all the usual conditions, that is the compressive and infiltrative conditions, the vascular to inflammatory disease, and of course, trauma. Toxins as a cause of cerebral cortical visual loss is not very common, but it certainly is or was common as far as the optic nerve was concerned. So the same conditions will again affect the optic nerve, the compressive, infiltrative, and vascular injuries, inflammatory, which is like, say, for example, optic neuritis and conditions like that, and toxin-related disease of the optic nerve. Now, toxin-related diseases, some of the drugs, which all of us know, but it's not common, and neither is methyl alcohol poisoning common now. Because the last case I saw was maybe 7-8 years ago, and that happened when some Sri Lankans distilled illicit liquor in Bangladesh, not in Sri Lanka. And I mentioned end-stage glaucoma. Now, if we look at the visual field losses, we can get the homonymous and heteromynymous, and sometimes you can have macular sparing. So these patients come in when we check their visual acuity can be surprisingly good. And if you're not alert, it is possible to miss a visual field defect, and especially if it is not a complete homonymous or heteronymous hemianopia, or if it's not a complete hemianopia. So if it is a partial hemianopia, it is very easy to miss these unless you're really alert and look at it. So macular sparing also can happen in these patients as well as in occipital cortical infarction, because the blood supply to the posterior part of the occipital cortex and the rest of the occipital cortex is different. So you can have one part being affected and not the other, and that can result in either the central vision being lost or the peripheral vision being lost. And of course, on the right-hand side, what you see is the typical presentation of end-stage glaucoma. They go on and on with a tiny little bit of visual field, sort of a tunnel vision, and then that can get suddenly wiped out, and they can present as an acute visual loss. So that is acute glaucoma. Sorry, that is a glaucoma which presents in its end stage. That is what you see there. I would like to dwell a little more time on the other causes of acute visual loss, which you're probably not as familiar as with neuro-ophthalmological causes. So any pathology affecting the macula can present as an acute visual loss, though a lot of the time they would present with a more gradual loss of vision. So macular edema from any cause, and of course the commonest cause of macular edema in Sri Lanka and most of the rest of the world, it would be diabetes. Central serous retinopathy is a condition which affects predominantly males and young males at that, maybe from the age of about in the third and fourth decades. And a very important condition for all of us is age-related macular degeneration. When I became a consultant in 1990, we hardly ever saw this because the lifespan at that time was in the 60s, late 60s. But now things have changed, and age-related macular degeneration is probably as common in Sri Lanka as in the Western world. Then we have vascular occlusions. Vascular occlusions are also extremely common. You can get the branch retinal vein occlusions, central retinal vein occlusions, and the branch and central artery occlusions, which are much less common than the vein occlusions. And of course, vasculitis. Retinal vasculitis is not a common condition, but we certainly do see enough cases. And all of these can present with very acute visual loss. And if we look at this is a condition called age-related macular degeneration, which is the leading cause of blindness in people who are over 65. And we have I have two slides, two pictures here. One is the one on the left-hand side is called dry AMD, where there is total atrophy of the macular region, the cellular destruction without any leakage. And on the left side is a condition we call wet AMD, where there is growth of new blood vessels which tend to leak. So there is exudation, there is retinal edema, and this tends to progress, causing severe central loss of vision. Now, dry AMD, though it is less severe than wet AMD, unfortunately does not have any treatment. So it's a progressive disorder where the central vision gradually gets lost, and there is really no treatment for it. The wet AMD has treatment. We use anti-VEGF drugs, which we inject into the eye, and there is a whole class of anti-VEGF agents. Some of them are reasonably priced, some of them are extremely expensive and is not within the purview of a lot of people. But they are effective in about 60 to 70% of the patients. And these are very, very important condition as the life expectancy in Sri Lanka increases. Now, these are from some pictures of optical coherence tomography, which is a widely used investigation now because it is non-invasive, it is extremely cheap, it's only the capital cost. The recurrent cost is almost zero if we don't use paper to print it out. And we use it extensively. So on the left-hand side, we have a normal scan, and that is the normal, this is the normal scan of a, okay, sorry. Is it mouse? Okay, fine. So this is the normal scan of the macular area. You can see the contour where there is the absence of except for the photoreceptors, all the other cells are absent. The bipolar cells and the Muller cells are absent here. And that's the fovea, the center of the macula. And this is a OCT scan of severe macular edema, and this is of diabetic origin. You can see the extensive edema here. Now, even these respond very well to anti-VEGF treatment, but this kind of edema would lead to a patient presenting with very low vision. And these can happen in a very short period of time. And when you see diabetics, they can present with fairly acute loss of vision due to this condition. And this is a OCT scan of a central serous retinopathy, which I was talking about earlier, where the two layers of the retina separate. There's fluid accumulating between the two layers of the retina, which causes separation and loss of vision. Okay, so okay, we have a few slides missing here. So I was briefly talking to you about central retinal vein occlusion. Unfortunately, I'm not sure exactly what happened to those two slides. Where I don't seem to be having it on this presentation. The central retinal vein occlusion and the branch retinal vein occlusion. The predisposing causes for these are usually hypertension and diabetes. Now, branch retinal vein occlusion also gives rise to severe macular edema, and they can present with sudden loss of vision. Central retinal vein occlusion is a severe condition, and if it is ischemic, they have very severe loss of vision, and which cannot be reversed. But we need to manage because they can progress to further conditions which can cause pain and total blindness. Retinal artery occlusion is not very common, but can occur due to thrombi being shut off from the aorta and the carotids. But that also can cause permanent and quite severe loss of vision. Then we come to retinal causes, acute loss of vision due to vasculitis. Now, vasculitis, again, is not a common condition, but when it happens, it's quite severe. We see it sometimes with cytomegalovirus, with herpes, and especially in patients who have HIV. Can get it in acute leukemias and, of course, in all the systemic inflammatory diseases. And this can lead to continuous, they can present with a loss of vision, and this can continue to progress, and they have to be treated very aggressively to try and preserve or reverse the visual loss. Now, media opacities. Media opacities is another cause for acute visual loss. And again, we have the biggest problem again is in diabetics. They can present with vitreous hemorrhages. Diabetes is usually not, how shall I say, the diabetic eye is not usually treated very well at present. We get a lot of patients with fairly severe diabetic retinopathy presenting for the first time. And they can present with this kind of condition where they have a vitreous hemorrhage. And if the vitreous hemorrhage is central or premacular, like in this patient, then they can present with an acute loss of vision. And you can see that there is neovascularization also just below the vitreous hemorrhage here. And it is very important now to aggressively treat these patients to prevent them from losing their sight totally. So this patient would require laser and then would require surgery to remove the blood. Acute metastatic endophthalmitis. Again, not very common, but certainly seen in immunocompromised patients, and the commonest is diabetes again. I had a patient recently, 34 years old, badly controlled diabetic, presented with this sudden onset in one eye, in the left eye, and within 2 days, it progressed. When I saw him in 2 days' time, it had progressed to an extent where the fundus was not visualized. Went in for surgery, and there was total retinal necrosis of the eye, and that was a Klebsiella infection. It's very, very rare, but it can happen in diabetics. So we have to be extremely careful when dealing with bad diabetics, especially with this acute metastatic endophthalmitis, and occasionally it can be bilateral, and the patients can become blind as a result of this. Then acute angle closure glaucoma is another condition. They may occasionally present as a medical emergency because of the headache and the nausea, rather than presenting to an ophthalmic unit. And then it is, you need to remember that sometimes it could be acute angle closure glaucoma. And of course, it is an ophthalmic emergency, which needs to be sorted out as fast as possible. But the most important thing I want to bring to your attention is the use of topiramate. Now, topiramate also causes acute angle closure glaucoma, and it occurs usually, it's given to very young people. I had a girl who was in her late 20s who presented with acute angle closure glaucoma. The diagnosis had been missed. And then in one eye, on the right side, she had a loss of vision due to the persistent increase in the intraocular pressure. So topiramate, when it is prescribed, the patients have to be warned that though the side effect is rare, that it can happen, and if it does happen, if they get pain on the one side or the other, then they need to be sorted out immediately. So before I finish, I would like just to touch on a potential acute visual loss. These patients present with full sight, but they can lose their vision in a very short period due to these two conditions. The unconscious patient. Patients are unconscious, their eyes are not fully closed, so what happens is the cornea dries up. When the cornea dries up, it cracks, the epithelium cracks, and then it is the infection can get in, or there can be a acute keratitis, and this is usually not detected because the patient is unconscious, and it can progress into the eye and cause an endophthalmitis. The first case I saw was when I was working for the military hospital. That was in 1990, when a soldier who was treated in one of the peripheral hospitals with ascending myelitis was brought to the army hospital intensive care unit, and I was asked to look at the patient because of the discharge from both eyes. He totally recovered from his ascending myelitis, but he was blind at the end because of bilateral perforation of, due to infective keratitis. And the last case I saw was about 3-4 years ago, when a young man was standing on the road and was knocked down by a truck. He was heroically, he had multiple injuries, very bad injuries, and he was heroically treated in one of the provincial hospital intensive care units. And his family was told several times that he will not survive, but he did survive. He recovered pretty well, except for the fact that he also had the same problem. He had bilateral perforation of his eyes with endophthalmitis. And first time it was detected when the eyes perforated. So we need to remember that these patients, this kind of patient is very important. If the patient is unconscious, ocular management is very, very important because they can potentially lose their sight. And the second one I want to bring to your attention is Stevens-Johnson. Stevens-Johnson syndrome also can present, and they can lose their sight very, very quickly unless seen by ophthalmologists and started treatment very early. So with that, I'm going to wrap up. Thank you very much for your patient hearing.
Thank you, sir, for that very informative and very interesting lecture. Just because we have run short of time, we don't have any much time to entertain any questions. On behalf of the Sri Lanka College of Internal Medicine, I would like to thank both speakers, and may I invite Roshan to hand over the certificates of appreciation. Dr. Primali Jayasekara. Dr. Charit Fonseca. Now we have come to the end of this session, and may I hand over the stage to the other people.